And I am Sean, the clinical patient and lab analyst number 5.
Yeah. Hi, my name is Francesca Nguyen, and I'm lab analyst number 3.
Hi, I'm Brian Campbell. I am lab analyst number 4 and also the narrator.
I'm Chloe Nickel. I'm lab analyst number 2.
Hi, I'm Joseph McCarty. I'll be playing Bob.
Psoriasis is a common chronic inflammatory skin disease. It typically presents as thickened, erythematous, scaling plaques which are often pruritic. Psoriasis has been associated with markedly elevated healthcare utilization, work limitations, and productivity loss. This, along with the clinically relevant reductions in healthcare-related quality of life experienced by many psoriasis patients, underscores the need for effective management with one of a number of potential drug therapies. Patients with moderate to severe disease often require systemic treatment. In the United States, there are 2 broad classes of systemic drugs to treat chronic plaque psoriasis: non-biological agents and biological agents. A well-done randomized controlled trial is published in a respectable medical journal that demonstrates for the first time that a biologic agent, adalimumab, is more efficacious than methotrexate. For treatment of moderate to severe chronic plaque psoriasis, specifically, a greater proportion of patients taking adalimumab achieved the trial's primary efficacy endpoint, a 75% reduction in psoriasis areas and severity index score, a psoriasis symptom score, compared to those receiving methotrexate. The trial further demonstrates that patients receiving adalimumab have better health-related quality of life, but also a greater theoretic risk of severe infections. As a result of these findings, Bob, the chairman of a large managed care organization, Husky Health Pharmacy and Pharmaceutics Committee, is asked to consider the economic impact of adding biological agents such as adalimumab to the formulary of this purpose. For this purpose, he needs to conduct a pharmacoeconomic evaluation to aid him in his decision-making process.
Hey guys, I was going through some articles this weekend and I found some trials for this new drug adalimumab. It's for plaque psoriasis, and I just wanted to see if any of you guys knew anything about it or if you think that we should actually carry it here at Husky Health. I haven't done any of the pharmacoeconomics on it at all, so I don't know if any of you have any insight into that maybe?
Well, based on pharmacoeconomics, we should take into account the cost of the biological adalimumab and its effectiveness in comparison to the non-biological methotrexate. And I also know that patients do not normally like the non-biological methotrexate because of the long-term toxicity. What do you all think about this?
Well, I actually have seen the clinical trial that Bob is talking about, and I can pull it up. Let's take a look at a few of the most recent clinical trial patients that they have. So as you guys can see from the images, the patient had a 75% overall reduction in the plaque psoriasis on his body. This was known to be the most common response in this clinical trial.
What are some other treatments for psoriasis that may help us determine if we should have it in our budget or not?
I know of one actually. It's called methotrexate, a non-biologic agent. Very cost effective. There is toxicity involved with it, but very cost effective.
In reference to that, I know that when you're talking about a non-biologic versus a biologic, it seems like the non-biologic has a smaller annual cost. That would be a good incentive for patients to have a non-biologic.
Now that we know all that, what are some of the negative effects of adalimumab?
Well, like we just said before, it's actually quite expensive as a biological agent. The average annual cost was somewhere in the ballpark of $18,000 to $25,000 per year per patient. So it's actually quite expensive if we were to choose to stock it. On top of that, there's actually quite a high chance of severe side effects afterwards. There's a chance of severe infections that can be caused when using this drug. So I feel like it would probably be in our best interest to not stock this drug, as it would be very expensive and it has the potential to cause a lot of harm to our patients.
Yeah, I definitely agree with you. If we conducted a cost-utility analysis, the incremental cost-utility ratio shown here, which I've written out for you guys, with that, we can use CUA to assess the cost-effectiveness of choosing one treatment strategy over the other. If we administer a biologic agent to patients for 5 years, which is shown here, it would cost $100,000. Treatment with methotrexate for the same period of time costs $6,000. Also, the biologic agent results in patients having an average utility value of 0.9 and 0.8 for the methotrexate. So based on this subjective calculation, many have determined that results in CU ratio greater than $100,000 per QALY, which is quality afterlife years, gain may not be considered cost effective. Our value suggests that the extra benefits of biologic agents to treat moderate to severe plaque psoriasis may not be worth the extra cost. So what do you guys think? I don't think it's worth it.
I agree.
Sounds good analysis.
Yeah.
All right, thank you all for your time.
Thank
I
you.
appreciate your input.
Thank you, Bob.
Sir.
Oh. And we're Team A.
Also, the average response, I can't talk.
It's okay. You got it.
I know, but I like watching him and not paying attention. I'm just trying it out. Hello. Hey guys, trying out the video. Hey guys, trying out the video.